Dr. Beiro, Dr. Buckley, and Dr. Swan. If you have particular questions, please put them in the chat room and we'll try to address them. And if we don't address them with the roundtable discussion, the doctors will be online to answer your questions. First question I have is an LET question for Dr. Buckley. We have similar outcomes with ACL and ACLR with the LET, but we have a lower failure rate with LET. So in the cadaver dissection that we did, the ALL ligament, it's not very robust. It's hard to find. We almost went through it, like there isn't like a big substance. Do you actually get an injury to the LET ligament or the anterior lateral capsule, or why is it that all of a sudden we need to kind of consider the ALL?
Sure. So there's a lot of ways to go about that. I think one thing is, this isn't a new concept. Like we said, this is the way that ACL surgery was done originally, is to address the lateral stability. So we're just coming back around to this idea, which happens a lot in medicine, frankly. There's a lot of alphabet soup here. And so an LET is not a structure, right? An LET is a procedure. Okay, so you're not going to have an injury to the LET, but the idea is that there is certainly a lateral capsular injury at the time of your pivot shift. And that if we're thinking about ways to limit that rotational instability to protect your ACL or protect your graft, that's a good thing. So I do think there's a lateral capsular injury in most ACL injuries. I think that we're finding the right indication for when to add that to a well-done ACL surgery. I still think that the gold standard is the right graft, fix your meniscus, think about other injuries and make sure to identify those. That's, the highway. And then there's certain indications that I'm adding an LAT. It's not every ACL reconstruction I do. But certainly these are things that are much more commonly thought about, now than 10 years ago.
And one extra question, would you consider somebody with a family history, brothers, sisters that had an ACL injury, do they get included into this kind of consideration?
From a orthopedic standpoint, my answer to that is no. I think from a practical standpoint, most families, if they've had somebody go through this and God forbid had a re-tear, for sure it factors in. And if mom and dad have, already went through this once and did all this and God forbid had a re-tear, you're going to want to throw the kitchen sink at this and not have that happen for kid number 2. So I think it does factor in. We know that that's a risk factor, but it's not a causative link. It's a multifactorial problem. So again, there's it goes into notch width and all these other things that are strings that you can pull for days here. So it's a kind of, it's my answer.
Okay.
Eric, I might add to that.
Okay.
It's been doing this long enough to see the evolution of our quality of research. And perhaps the MOON network, the Multi-Center Orthopedic Outcomes Network, which is a long-term prospective study on ACL injuries. Dr. Buckley's fellowship and my fellowship are part of that. And we've gotten really good data on this evidence-based research. And perhaps during my training, the beginning of my career, evidence-based medicine was a new term. And this is an evidence-based symposium here that we're really trying to follow the data better. So in the old days, all the ACLs did well, right? They all did well. They all went back to play. But the reality is, when you really study it, and we have good data, good studies, long-term studies now, we see that it's a little more humbling, and they don't all do well. And with that, then we start to recognize the risk factors for re-tear. And once we started to really understand, and we're still learning who's at risk for that re-tear, then we can try and figure out who needs the LET, which that's part of the reason why it's come back around. So we're trying to prevent those re-tears, or certainly if they have retorn, prevent the re-tear, which unfortunately we've all heard about.
All right, a question for you, Dr. Swan. With multi-ligament knee injuries, we do cover 2 major trauma centers, as I noted before. You've done a good number of multi-ligament knees with Dr. Buckley involved with that as well. Both of you did a great presentation at NATA a couple of years ago I'm talking about management of multi-ligament knees. Recent study, level 3 study that just came out in Sports Health, where they talked about looking at ACL injuries plus ACL plus MCL, so a multi-ligament knee injury, that at 1 year, they're saying that 10% of their patients that they studied were back to the same level of activity in athletics, with a multiple ligament injury. So a little longer, multiple ligament injuries complicate the whole, kind of picture with the knee. Knowing what you know about multi-ligament knee injuries, what do you tell a family member or a close friend or your patients about the process, about the picture that they now have to deal with a multi-ligament knee?
Yeah, so these are difficult conversations. And as I highlighted in one of my slides, it's individualized because each one of these are different. If it's at the trauma center, it's a motor vehicle accident, a motorcycle, and they have a head injury and a chest injury and a pelvis fracture, that would be very common in association with in combination with the knee dislocation. So they have a lot of stuff to get over, and they may have a social situation. They may not have a good social network. They may not speak the language. They may not have insurance. There's a lot of stuff that goes on with these people. And oftentimes it's, when are they gonna be able to walk? Are they gonna be able to walk? And that's the goal. Yeah, they want to get back to their job and maybe they want to get back to running, but oftentimes it's just, can they walk? And that's a victory. But it's a little bit harder. That's an easier conversation in a way because they have so much stuff going on. They just want to be able to walk. The isolated knee injury and the high level athlete, certainly someone who's like getting recruited or at the peak of their career, and now they have this injury and it's different than their teammate who just had an ACL. So that's a tough conversation. If it's a Zach Miller, like that was a terrible injury and everyone knew it right away and they kept replaying it over and over and over again. That was not your standard injury and that's gonna take a long time. But bottom line is, they're not coming back next season. They're out for more than a year. That number seems, awfully low to me, but still, most likely they have more than two or more ligaments reconstructed. They're probably not coming back from 12 months or more.
Okay. Question for Dr. Beiro. MACI procedure, covered by insurance? How expensive is it? Is it out of pocket for the patient? Do you know, like cost-wise? I mean, it seems kind of sexy to go grow your own cells in a lab somewhere and then put them back in your knee. I mean, that seems like the sexy way of doing things, but how viable is it for a regular patient with insurance that doesn't want to pay a lot of money out of pocket?
So that's a good question. I think it's become definitely more accessible than it used to be. Autologous chondrocyte implantation has actually been around for probably a number of years, close to almost 20 years, where they've actually taken these cells, regrown them, and put them back in the knee. Just the technology has developed now to the point where it's actually included in like this jelly matrix type, where we just kind of implant it as one patch. Before, we used to have to take periosteum or different kinds of tissue to basically put over the cells that we would inject directly into the lesion. So during all that time, in the beginning, it was completely experimental. As more literature has come about and shown mid to long-term results being a lot better, it's now covered by most insurances, but it's still very, very costly. And unfortunately, not accessible for charity care patients or self-pay patients. Would probably be exorbitant to pay out of pocket.
Okay. A question kind of for the general group. So a project play with the Aspen Institute looked at a study from 100 high schools reported by athletic trainers from 2007 to 2022, and they found a 26% increase in youth ACL injuries. And you can see there's been like kind of this gradual progression of what's going on. The incidence is more in females than it is in males. Non-contact injury is pretty high in females. Why? And what can we do about it as healthcare professionals, athletic trainers, orthopedic surgeons? What can we do preventatively What are our causes? Help us.
So, yeah, I mean, there's a lot to unpack on that, obviously. I think that the topic of, use specialization is something that like everybody in this room knows it. We see it every day. Getting that message and then changing behavior is a totally different thing, because from a societal standpoint, there's a lot of pressure for Johnny to play, that sport every day, all year round, because Johnny's going to be the next, Derek Jeter, right? And so we see it, and so I think the big thing from a practical standpoint is just trying to educate patients when they come in, most commonly with an overuse injury, and we've gotten a lot better data now to say that, but it's not really what most people want to hear. They want to know, how do I get my son or daughter better? So yes, it's a problem. I think the reason for the increase in injury is what we all know is if you're going to play a pivoting sport, if you're going to play soccer year round and you don't give your body time to rest and allow different muscle groups to heal, and cross train with other off seasons, et cetera, you're going to have a higher ACL injury rate, right? That's not rocket science. How do you change that behavior? It's hard. I mean, it's a huge industry. I think it's education. And for me, a lot of it is like having those discussions at your kind of preseason physicals or clearance type things. And that's one thing I've tried to do a lot more. We're not doing that, right? Orthopedic surgeons are uncommonly doing that. It's usually their pediatrician or something else who are not necessarily adept at identifying those risk factors of maybe looking at their hip internal rotation, looking at single leg squat weakness, where they go into valgus. Like those are to me way more effective screening tools than, what I saw when I was doing clearances and residency and everything, and you're just doing some simple cuff testing, whatever. 15-year-olds don't have cuff tears, right?
Mm-hmm.
So like we should probably be thinking about those screening tools and identifying, hey, look, you're at a risk for injury because you're playing soccer 12 months out of the year. That's way better use of our time than trying to find the needle in a haystack in this clearance thing. So
I would also add too that I think the literature has shown the efficacy of doing prevention type programs and education programs for athletes on simple things like how to land, how to jump, and a lot of these things may prevent some of these ACL injuries, particularly in the female population.
We often say that physicians are the worst patients. Well, we're also culprits to this whole sports craze. My eighth grade daughter is on 3 lacrosse teams and 1 soccer team right now. That seems to be the worst time, is 8th grade. They're on all the middle school and club and recreation or whatever. So it's hard to push back against that. I do exactly what Dr. Beiro said. With her, when we have spare time, we do a little bit of an ACL prevention program in our backyard, hoping that really, can decrease it ever so little. One of the elephants in the room that ought to be discussed is field turf. When did that all start? 2007 or so? Is that a part of it? And that's it's a conspiracy theory, but there's data out there that's biased, that showed no difference, and then there's other data out there that does show some difference with some of the injuries we see, and we don't have a good answer as to what footwear to wear on turf. Should there wear sneakers? Should there wear spikes, moldy cleats, turf shoes? So that's a nice place to do some research. And then, is the field turf going to evolve, be safer?
I think the question with turf too is there's so many variations of turf and the maintenance of different turfs that everybody's playing on. Is this a turf that's in Rutgers Stadium that's fully fluffed up and, nice and manicured, or is this at a rec department where, hasn't seen any maintenance or any refill of pellets or ever? Does the field turf field, is it being a little softer and absorbing a little bit more of that foot impact as it hits the grain, or is it more thinner pile? I mean, I think there's a lot of different things that you can kind of look at.
I would say from a practical standpoint, the other thing that I've seen grow is trying to get coaches more involved, right? Because I'm not at every practice in the world, you guys aren't as well. Coaches buying into this, I think, is a big part of it. I think baseball has done a pretty reasonable job of that with like the pitch smart data and trying to get people more aware of throwing injuries. But expanding that to sports and like, there's some controversy, like getting coaches aware of what a FIFA 11 ACL prevention program is. That's great. Expanding that to every sport out there, and that's where it probably needs to happen, is from a coach standpoint.